Hello and welcome to this Infrastructure Victoria webinar where we are going to be looking very closely at community health infrastructure and unpack Infrastructure Victoria's latest research on this subject, and also answer some of your questions that you might have on this research. I'm Jonathan Spear and I'm the CEO of Infrastructure Victoria, and I'd like to welcome you and thank you for joining us today. Before we go any further, I'd like to acknowledge the traditional owners of the lands on which we're meeting as we're doing this webinar. Here at Infrastructure Victoria's offices in Melbourne, we are on Wurundjeri country. So I would like to very much acknowledge the traditional owners, the Wurundjeri people, for the lands on which we are working here, and pay my respects to elders past, present and emerging. And of course, acknowledge that there are community health organisations, including Aboriginal community health organisations, working across the states on all the country of Victoria. Now, today we are going to be presenting to you the research that Infrastructure Victoria has undertaken. We are the state's independent infrastructure advisor, and we're really looking forward to unpacking this research on community health infrastructure. My colleague Llewellyn Reinders is going to join us for that, and then we've got some special guests as well. What you'll be able to do is ask questions. So you'll see underneath the screen that you're looking at right now, there's the Slido. You can put in your questions and we'll aim to get to as many of those as possible in the second half of this webinar. So I'm really pleased to now welcome my fellow participants on this webinar. So we have Llewellyn Reinders. Thanks for joining us, Llewellyn. Llewellyn is Director of Research and Policy here at Infrastructure Victoria. I'm also really pleased to have Anna Robinson join us. So Anna comes to us with two hats on today. She's a chair of Community Health First, but she's also the CEO of Access Health and Community, so one of the community health services. And Lee Clark is joining us. Good morning, Lee. Thank you very much for joining us. Lee is CEO of the Victorian Healthcare Association. So Anna and Lee will be joining us for the Q&A later on. We're really looking forward to hearing their perspectives on this research, and they'll also be helping to answer some of your questions. Now, if you're interested in diving into this research that we've published, you can find it on the Infrastructure Victoria website. For those of you who've been following our work, you might also know that we've published work earlier this year on Aboriginal community health infrastructure, which we did in partnership with the Victorian Aboriginal and Community Health Organisation. We're very pleased to do that, so you can dive into that. And there's also a webinar available on our website with the wonderful Auntie Jill Gallagher, who is speaking there with me and around this research that we did earlier, which is very complementary on Aboriginal community health infrastructure. So with that, now let's turn to have a bit of a run through the research. I'm going to hand over to Llewellyn. He, along with the team, is instrumental in undertaking this research. So he's really well placed to talk us through, why we did this work and what we found and some of the recommendations that come out of this research that have been now made to the Victorian government. So thanks, Llewellyn, and I'm going to hand over to you.
Thank you so much, Jonathan, and thanks everyone for dialing in today. I'm really glad to share this work that we have done over the last year or two. And look, I'm really aware that many of you come from community health organisations. Perhaps some of this information you already know and it seems obvious. But I'm really aware through the course of this work, we became aware that beyond the health sector, many people weren't really familiar with community health and what they do. So I think it's really useful, particularly for those who aren't from the sector, to understand the community health sector and how it fits into the health system. So Victoria has 79 community health organisations, and there's two main types of them. We have integrated community health organisations, which operate as part of Victoria's hospital system, as well as registered community health organisations, which are independently managed not-for-profit organisations. And at the beginning of this year, there were 24 registered community health organisations and 55 integrated ones. Although I think the numbers have changed as there are mergers going on all the time in the sector. So community health organisations provide health services, but also other services like social support services and health promotion programs. And those services are typically free or low cost. And they target those services for people who are most at risk of poor health and have few other options to access these services. And that mix of community health services is part of the power of the platform. And we've adapted this diagram from the registered community health sector, which really shows that, placing healthy individuals and communities at the heart of their services, wrapping around that medical services, so health services like general practice, dental care, nursing, or clinical services for drug and alcohol and mental health. But beyond that, also offering services that can deal with some of the social determinants of health, like housing and homelessness services or employment services or family violence programs. And in addition to that, being able to offer health prevention services like fostering healthy environments or building health literacy. And bringing this mix of services together and being able to connect people quickly and easily to low-cost services they need, gives community health services a powerful platform to improve health in the Victorian community cost effectively. Community health organisations typically receive funding to deliver the Victorian Government's community health program, but we also know across the sector that's only a small sliver of their funding. They also receive funding from other Victorian Government programs, the Australian Government, non-government sources, and client fees. And looking at the statistics for the registered community health sector, they receive about half their revenue in total from the Victorian Government and around 28% from the Australian Government. And we know the services that community health organisations offer work. Community-based primary and preventative health services, which they typically offer, have significant benefits. For example, preventing and treating heart disease and diabetes can return $9 in economic and social benefits for every dollar invested. Similarly, some public health interventions can return over $14 in benefits. And we also know that one of the biggest causes of preventable hospital visits in Australia are dental problems. And community health organisations are one of the major partners in delivering public dental services in Victoria. But we also know that our hospital system is under pressure. And in fact, 2 years ago, there were over 500,000 emergency department visits in Victoria that could have been avoided if they were managed in the primary and community health sector. And delivering those services in emergency departments cost the Victorian Government over $500 million a year. And we also know that Victorians experiencing disadvantage, precisely those targeted by community health, are more likely to end up in hospital for health problems that could have been prevented or treated earlier. And so with the right infrastructure and service planning, community health organisations can help ease demand on hospitals by efficiently managing more of these cases in the community. And the community health sector has a broad reach. So in front of you is a diagram showing all of the community health facilities across Victoria that offer 3 or more services. And as you can see, it's a widely dispersed platform that can reach communities right across the state. So coming to our research, and we really wanted to understand what is going on with the infrastructure for these organisations. So we did a number of different things. We conducted a consumer survey of over 4,000 Victorians on their community health use and their preferences for using it. We also worked with the registered community health sector to survey their infrastructure and ask them about the quality of the infrastructure and the effect it was having on their services. We also mapped the location, as we saw on the previous slide, and assessed how easy it was to get to community health services by car and public transport. And we also talked to community health managers. to understand the nuance of their day-to-day work and how infrastructure was affecting it. And what we found firstly is there is growing demand for community health services across Victoria. And our survey showed that about 45% of eligible Victorians hadn't used a community health service in the last 5 years. And when we asked them why, they very much indicated that long wait times were the biggest barrier to them accessing the service. We also looked at population projections for the future when we mapped community health organisations, and we found that in some places in Victoria, the population in those places will more than double in the next 15 years. And that also will add demand to community health services and indeed health services across the community in those places. And they tend to be in growth areas around our major cities, which are also the places that have the least developed health services and the least developed private health system as well. And from the data we could find, such as in mental health, we know there is large projections in demand for community health services. So in mental health, the Victorian government itself has estimated that those services over the next 15 years will at least double, if not increase by about 5 times in a 15-year period. Another way of looking at that is looking how many people can access easily a community health service over time. So this diagram shows the proportion of the population that can reach a community health service in 30 minutes on public transport now and 15 years from now. And what we see, it's particularly in Melbourne's growth areas where that access will reduce over time if there isn't more sites or services available to them. So for example, in the growth areas in Melbourne's north, there'll be a 12% reduction in the percentage of people who can reach a community health service in 30 minutes by public transport. But when we looked at the infrastructure itself, firstly, we found a number of things. Most registered community health organisations use buildings they don't own. And over a third of those buildings are owned by the Victorian government or local governments, and over another third are privately rented from the commercial sector. And when we look at that infrastructure and those facilities, we see that community health organisations are sometimes operating out of old buildings intended for another purpose. For example, some use repurposed public buildings like former hospitals or commercial office buildings. We also know that the quality of these facilities is in pretty poor state. More than a quarter of the buildings used by registered community health organisations are in poor condition or at the end of their life. And when we look at how those are distributed, nearly every community health organisation has a building in poor or end of life condition, with around 90% of them telling us that they did. And when we look at who owns the buildings and what quality the buildings are in, we see that the worst owner of community health organisations is the Victorian government itself, with about half of those buildings in poor condition or at the end of their lives. And those poor quality buildings are affecting the amount of service community health organisations can deliver and the quality of the service they can deliver. So they told us that 40% of the buildings they are working from have an infrastructure problem that affects their service delivery or capacity. That limited space or poor facilities meant the organisations weren't able to provide more services from that location, even when they had funding to do so. It meant they had to forego funding or involvement in a program because there was simply no point in applying for it because there was no space to deliver the program. And it also limited the number of services provided, contributing to those longer wait times, which people identified as the biggest barrier to access. And again, when we look at the different ownership groups of those buildings, those in the worst condition were owned by the Victorian government, with about 2/3 of them having one or more infrastructure issues affecting the delivery or the capacity of services being delivered by the organisation. The other thing we found was there are quite a number of buildings being used to deliver a single program. And this somewhat undermines that benefit of providing that wraparound connected set of services that community health can be very powerful in creating. And by co-locating services, community health organisations can reduce the travel burden for clients. They can make it far easier to refer clients to other services and can help service providers collaborate together to get better health outcomes for their clients. But because so many buildings, and quite often, a community health organisation will get an extra funding stream, they don't have enough space, so they have to go find another building to offer that individual program. Because they don't have the space and the capacity to integrate their services, we can't get the best quality of care with the current infrastructure we have today. We also looked at how community health organisations receive funding. This is particularly for registered community health organisations, and we looked across the many funding streams that fund infrastructure, health infrastructure across the Victorian government, and found that while the Victorian government spends about $2 billion a year on health infrastructure, only a very tiny sliver of that is actually granted to community health organisations. Community health organisations do have access to some of the infrastructure funds, like the Metropolitan and Regional Health Infrastructure Funds, but they were not very successful in actually receiving grants from those funds. And when they did, there were very small amounts that couldn't pay for a large upgrade or a rebuild or an expansion. And what we see is because community health organisations pull together funding from so many different sources, from local government, from state government, from Commonwealth government, many of those funding streams are premised on somebody else providing the infrastructure. So the funding is provided for the service, and the assumption is that the infrastructure will come from somewhere else. And there's no systemic or coordinated mechanism to plan infrastructure for the future and make the best selection and investments of infrastructure funding to accommodate the expectations of future health service delivery by the sector. So we've made 3 recommendations in this report to the Victorian government. The first of those is to get a good handle on what exists and what condition it is in. So that is to conduct an asset assessment of all community health facilities, including both integrated and registered, so we can understand where the problems are, where the biggest risks are, and which things are most urgent to fix. Our second recommendation is to actually then develop the plan about what we would like to see in the future and what is needed by the sector to deliver high quality integrated services over time, with an expectation and an understanding of the size of the service delivery task in the future. Once we've done those 2 things, we can start investing in community health facilities in a coordinated way that understands where the most urgent priorities are and where the growth needs to come. So we have made an estimate based on the information that we gathered in our survey, that if we funded some of the most urgent priorities, particularly those buildings that were coming to the end of their lives or needed major repairs, that might cost around $150 to $300 million over a 5-year period. So very quickly to sum up, and I'm very aware that, It'll be fun to get into a bit of conversation about some of these issues, but Victoria's health system faces high demand from rising health costs and more complicated care. Managing patients in community-based services can help avoid unnecessary and expensive emergency department visits and hospitalizations, potentially saving millions of dollars. There is significant demand for community health services, and this is likely to rise in the future, especially in growth areas around our major cities. But many community health organisations operate out of old or unsuitable buildings that have leaking roofs, structural issues, and designs that impact their ability to deliver services, compromise the quality of those services, and affect the efficiency which those organisations can deliver them. The Victorian Government is the largest funder of registered community health organisations, and we think it can invest in infrastructure improvements for those organisations, and that would cost around 1.5 to 3% of the $2 billion the government spends on average each year on health infrastructure, which is a relatively small amount. And we also note the Australian government has a role to play here as well, and the Victorian government can seek contributions from them as well. That is my very quick roundup, and I think I did it in about 13 minutes, which I think is a record for me, but we're really keen to get into the conversation, so I'll hand back to Jonathan.
Great. Well, thank you very much, Llewellyn. That's a really excellent overview of the research. And it is, as you said, time to now expand the conversation as we bring in Anna and Lee to this conversation. A reminder to those of you who are watching this to keep your questions coming in the Slido, and we're going to try and get to as many of those as possible. But Llewellyn, you've given us this sense of the interplay that the community health sector has in supporting the way the broader health sector works, especially hospitals, but not just hospitals, but also that really complex interchange between the quality of the community health infrastructure and the services that are provided. And I think that's a really great jumping off point to start with Anna and Lee. And Anna, I might go to you first. Tell us a bit about the two organisations that you represent, which are both slightly different but important roles in the community health sector. And what's your sort of overall take on this research before we kind of drill down into the fine detail?
Yeah, thanks, Jonathan, and thanks for having me. Really excited to be having this conversation. Think it's long overdue. So yes, I am wearing two hats. So in my day-to-day, I am the CEO of Access Health and Community, which is one of the registered independent community health services, predominantly operating across the inner east and into the outer east of Victoria. And in addition to that, I also am very fortunate to chair Community Health First, which is the alliance that brings together what is now 22. There have been a couple of mergers since the research was completed, independent registered community health services. And we really come together with a view to looking at how as a sector we can better contribute to the health and wellbeing of Victorians and help solve some of these really tricky challenges that our health system is facing. And yeah, look, I think we absolutely welcome this piece of research and really pleased to have worked with Infrastructure Victoria to really map out the infrastructure needs of the system. I think it's one of those issues that's probably flown under the radar for quite a long time, and I think really starting to think very strategically now about the role that community health can play in alleviating some of the challenges in the health system and the important component of infrastructure in that. It's really timely, I think, Jonathan. So looking forward to some robust conversation and some interesting questions.
Great, thanks, Anna. And Lee, let's now go to you. Welcome again. So you're from the Victorian Healthcare Association. Tell us a bit more about the association and how it interplays with both community health and the broader sector, and what's your overarching take on this research?
Yeah, thank you, Jonathan, and thank you for the opportunity to join you today. So the Victorian Healthcare Association is the peak industry body for Victoria's publicly funded health services. And probably most typically, I think the general public might be, familiar with hospitals and healthcare services, which is probably front of mind. But our organisation represents the far greater diversity of services that contribute to healthcare in Victoria. So that includes our registered and our integrated community health services, as well as some of our other non-bed-based services such as patient transport and bush nursing centres and palliative care and the like. So really cutting across the full diversity of both bed-based and non-bed-based services. And collectively, the membership of the VHA, contributes to about 31 billion of healthcare investment year on year, which is about 30% of the state's budget. So there's a really important conversation about how we invest and how we invest well. And I think from the VHA's perspective in terms of this report, it's, as Anna mentioned, it's timely, but it's really important to bring forward a conversation about infrastructure that extends to the full breadth of services that are important to the Victorian community. So I think it's really timely, and it's really nice to be able to dig down into some of the details, like Anna, keen to have a robust conversation. So thank you, Jonathan.
Yeah, well, Lee, let's get that going then, and let's jump off then from your point about services. So we've got some good questions coming through about the interplay between infrastructure and service provision, and the questions are really coming around. Well, if there's additional infrastructure provided or improved for community health services, how quickly can community health services scale up to use that infrastructure? Maybe the other thing that we found in our research, which you both might want to comment on, is the limitations of existing service funding because of inadequate infrastructure to actually deliver those services. But Anna, would you like to start, as a CEO of one of those services? Well, what's the reality of both scaling up, but also using the service funding you've already got, and how that interplays with the infrastructure?
Yeah, I mean, on the issue of scaling up, I mean, I think it's right to be asking the question around services and service funding, because I think infrastructure, right, is only one part of the challenge that we face. We also face the challenge of, if we have the great infrastructure, we also need the funding to deliver the services as well. So I think we can't lose sight of that. I think community health is an inherently scalable model, and in fact has been able to scale up really quickly, particularly if you look at the COVID-19 pandemic. We had services standing up testing centres in a matter of days to support the community. So I think our ability to do that quickly has been pretty well proven over time. The challenge we have is that we often get funding and then we have nowhere to deliver it. And speaking with my Access Health and Community hat on, we've just recently opened a new site out in Doncaster, and that was a huge undertaking that took us several years to do. And part of the reason we had to do that is because over time, we had secured all of these bits of funding and had to stand up new locations. And so we actually had 4 different sites operating in one local government area, which was incredibly inefficient, but also really, really bad for the community, because they couldn't actually access all of those services in one place. And we see this replicated right across the sector, where we're having to invest in multiple sites, often at a sort of an increased cost to the system and to the organisation. So it's definitely having real world impacts for most organisations.
Thanks, Anna. And Lee, what's your perspective on this issue?
Yeah, absolutely. I think you can't have a conversation without infrastructure, without having a conversation about service and how those two go hand in hand in terms of funding. But I would point to probably 3 sort of key things around this interplay between service funding and infrastructure funding. And that is, there are plenty of examples of services right now that have got wait lists, which is indicative that the service funding is there, but usually it's the access to infrastructure to be able to deliver the services. So rooms that are too small, not fit for purpose, unable to be accessed due to stairs and things like that. So there's examples where the funding is there, as I think it's what Anna is pointing to as well. There is also a conversation about concurrent funding, about where the funding comes from as well. And I'm sure we're going to dig into that a little bit further. But I guess I would also point to the fact that it's about opportunity. So as we see rising demand, we see increasing chronic disease, we see reforms at the federal level as well. So aged care, mental health, We've also got the NDIS reforms that are occurring. These are all likely going to drive increased servicing and increased funding opportunities into community health. The infrastructure is going to have to match that. So I think there's an interplay there, but I think there's a long-term vision down the road in terms of investment in services and infrastructure concurrently.
Yeah, and Lee, what that points to, I think, in part is the benefit of aligning service planning with infrastructure planning.
Absolutely.
And one of the recommendations that Llewellyn touched on is that kind of need to have service plans, infrastructure plans lining up and clarify the role of community health services in delivering services in the future. And one of the questions that's come through has been around the opportunities to collaborate with health service network clinical service plans, so that there can be a look at, well, which of the integrated service providers are going to deliver services, which are going to be the registered, how's that going to work? What's your view around those opportunities for service planning and the different components of the community health system, let alone the broader system, in meeting those service plan needs?
Absolutely. Great question. So we can't have a conversation about community health services and what they can offer to the Victorian community without considering how they interplay with the broader sector as well. So as you mentioned, we know that there is clinical service planning occurring across the state as we move towards a network model for hospitals. There's lots of conversations about the opportunity to deliver care in the right place at the right time, and how do we remove, entry into the hospital system and place that care into the right place, so into the community. And we see that in lots of spaces. We see, aged care being delivered in the home. We see lots of different services increasingly being delivered into community, such as the NDIS. And it's not unreasonable to think that community health services don't provide an opportunity up against the acute sector. And we see that with how integrated community health services work in the hospital system. There's lots of examples of health services, and I'd point to Delkaya Health as an example, where Delkaya Health has amalgamated with a community health service that was independent for a long period of time, and they are able to seamlessly coordinate care between the hospital and the integrated community health service. But that same coordination, clinical service planning and opportunity exists in the relationship with community health services that are registered as well. So I hope that answers your question to some extent.
Yeah, it does, Lee. And in a minute, we'll move on to some of the funding issues. But since we're talking about services and service models, there's some great questions coming through around some of the way in which that can complement both hospital services and community health services. So Maya Cubit has asked a question around home-based community health services and what the opportunities there are for home-based services to complement and to some degree reduce the need for infrastructure. And we've got another question about the ability to deliver community health services alongside other government services like public housing. And certainly in our report, we point to some of those case studies where you've got co-location of public housing and community health services. But Anna, what's the reality and what are the opportunities in terms of co-location, but also delivery of services in the home?
Yeah, I mean, most community health services already deliver a fairly extensive range of services in people's homes. So often the community health centre or the fixed location is a bit of a hub, and you have staff travelling in and out of that hub. So I know, speaking for my organisation, probably a third of our service delivery would happen in people's homes or in other community settings as a part of the sort of routine care. It doesn't remove the need to have that hub model though, and I think particularly for some types of services, you absolutely need people to be coming into a clinic of some description. And it's also that piece around giving people a space for that connection into community, which I think is a really important part of the community health model. So that's absolutely part of it. And I do think that co-location piece is a really important part of that planning piece. So we know we've got some really good examples of community health services that are co-located, particularly in social housing. So North Richmond Community Health springs to mind here, very much part of that public housing community, I think there's a really significant opportunity there as we're planning out social housing to really be thinking about the role of community health in that infrastructure as well. And I think that's the piece that long-term vision for community health infrastructure and setting that plan could really help deliver.
Yeah, thanks, Anna. And that's certainly consistent with a lot of the feedback we had when we were doing this research, didn't we, Llewellyn? You might want to expand on that, but we've certainly heard that from a lot of stakeholders, haven't we?
Absolutely. And quite a lot of stakeholders talked about, the opportunities of combining health infrastructure funding with with other infrastructure funding across government and across levels of government, because governments at all levels spend many, many billions of dollars on infrastructure in Victoria each year, but we don't necessarily have good mechanisms to combine that funding to produce something greater than the whole of the many parts. And we spend a lot of time building single sector facilities when in fact some of the biggest benefits of those facilities could be bringing it across and co-locating different types of services together. And community health, I guess, is illustrative of the many different agencies and funding sources that they use, combining health services with social services, for example. Yet bringing together those infrastructure funding sources can be very challenging in the way that government plans.
Yeah, absolutely. And I think that's a pretty good segue then for start talking about funding. So Lee, I've got a question for you. This is not a game show here, where this is a very serious program that we run here in Infrastructure Victoria. But the question might sound like it's a $2 billion question.
Okay.
So the $2 billion question is, if community health organisations can save emergency departments about 500,000 visits a year, but we're spending about $2 billion a year on health infrastructure, why is nearly all of that going to hospitals and not very much of it going to community health? It's a very popular question that's coming through on the Slido, so you get to be tempted to have the first go at answering the question.
I bet it is. So I guess the first thing I would say is that the first challenge is visibility, isn't it, right? So this is the first report, I think, of its kind around infrastructure needs in community health. And I think there's a lack of visibility over time of what those needs have been. And I think to the point that Llewellyn made around all the different funding streams. So there are examples of some community health services that are aggregating up to 125 different funding streams. Now, those streams are paying for services only, and each and every single one of them that's being administered is not necessarily looking at the requirements of infrastructure that sit behind that. So I think first and foremost, there's that bringing together of the whole, as Llewellyn talked about, and considering what is the foundational needs that are underneath it. But of course, bringing that conversation into the $2 billion conversation, into the sector-wide conversation, is probably the important piece. So I think there's good reasons for investment into the community-based services that are going to unload the pressure on health services, but just unload the pressure across the community in general. So a conversation worthy of having, and I think it starts here, Jonathan. It's probably why it hasn't happened before or as publicly as what we're doing now.
Yeah, I think we'd agree with that, Lee, and we see that across actually a lot of the infrastructure sectors that Infrastructure Victoria looks at, where there's been a big build, over the last decade or currently, and in many instances that's a really needed big build. But there's opportunities to make the best of that big build and extend its life and its impact on the community by sometimes smaller investments that really amplify the effect.
Yeah, and I would concur with that in terms of maintenance as well. So being able to really have good transparency over what is the maintenance needs, so that the conversation isn't always about just the big build or the complete new build, but also how do we extend the life of existing infrastructure that's in place.
Yeah, and now let's turn to you now. Talk to us a bit about the reality of the different funding streams that community health organisations have to deal with, and Llewellyn sort of outlined the diversity of some of those, and maybe a particular question that often comes through, or maybe even a misapprehension, which is, oh, you're delivering primary health. Isn't this the role of the Commonwealth government? Shouldn't the feds be paying for this stuff? How does this play out in reality?
Yeah, and look, I do think that this is actually probably the major challenge for community health and possibly why we haven't solved this infrastructure problem until hopefully now, is that there is a bit, we sort of fall into this too hard basket because a little bit of what we do is federally funded, but we're also funded by the Victorian government. And then even within the Victorian government, we have health funding, we have funding from the Department of Families, Fairness and Housing and various departments. And I think governments like things that fit neatly into one basket because then it can be allocated to one person whose job it is to solve that problem. And, the beauty of the community health model is the complexity of the services that we offer, because that is actually what allows us to deliver a service that meets the needs of the community. But it also makes it a much harder problem to solve when we need additional funding or support for infrastructure. So I think it requires, from my view would be, it requires a very different way of government thinking about how it funds some of these challenges, and really being willing to break down some of those siloed barriers around how we think about investment. I think the thing that I do keep coming back to, though, is ultimately we are part of the Victorian health system registered under the Victorian Health Services Act. And, part of what the Victorian government is doing in investing in community health is investing in that platform that then allows us to bring all of those other services and funding streams to bear to benefit the Victorian community. And so ultimately, this infrastructure investment is about building on that platform and making sure there's a really strong foundation there for those services, regardless of where they're funded from. But yeah, a little bit of a different model needed to how we think about investment.
Yeah, it really isn't a strikingly powerful platform that community health organisations have to wrap those services and those different streams of funding around the most vulnerable members of our communities. It's just that the funding streams that sit behind them don't always reflect that. And we found a similar thing actually with the very effective Aboriginal community health platform as well, which of course, really integrates so many benefits for Aboriginal people into the platform that they deliver on, but has similar challenges in terms of reliability of funding streams.
And ultimately, what our communities want is they just want to be able to walk through the door or call up their local service. They don't know what funding they're eligible for. They just want help. And that's our problem to solve in the background, is what funding they're eligible and what services they need. We don't need the community. We don't want the community to have to figure that out for themselves. And I think that's the problem that community health solves for community members. So we make it easy for them to come and get the services they need in one place.
Yeah, absolutely. And of course, getting funding is a competitive thing, and a number of the questions that are coming through are reflecting that, and the competition and lobbying that goes on, which is the way of the world. Lee, you see across the whole of the health sector. Do you have a view about how community health might better reflect and call for greater prominence and investment in community health in seeking additional funding for infrastructure as well as the services that underpin it?
Yeah, I think what I pointed to before was around just the visibility, but also the clarity of the need. And then I think at the moment, what we're really having a conversation about is the opportunity cost. What is the lost opportunity by not investing in the infrastructure for now and into the future? And so I think it's about bringing that conversation forward really clearly, which is what we're doing. But the other thing I would add is around when we're looking to advocate for investment into community health services, and in particular infrastructure for registered community health, what is the actual burden of the current system, the current mechanism in which community health services are advocating and lobbying or applying for funding within? And is that the most appropriate structure for community health services to be working within? So if we look at the Metropolitan and the Regional Health Infrastructure Fund, these are really large funds that are incredibly competitive. They cut across all of acute services as well as community health services. The need is enormous, so it's hard to compete in that space. And I think that's evidenced by some of the stats that you've brought forward. I think from one of the years there was 19 applications, and I think maybe 4 were funded. So there were 15 registered community health services that spent a very large amount of time investing in applications and grant funding, resources and finances that were unsuccessful, and will probably likely resubmit and do the same thing year on year. So is that the most appropriate mechanism, or is there an alternative way for us to build a strategy, which I think is to the second call for action in your report, is how do we prioritise and have a strategy and reduce some of the burden, the competitiveness. I think that would be my point for that, Jonathan. I think it's really about a new way of thinking, which is what Anna pointed to.
Yeah, and that sort of relates and I think responds to some of the questions that have been coming through about how do we break the very short-term funding cycles and the year-on-year funding and have that kind of longer view and greater consistency and predictability of base level funding combined with greater clarity around how community health fits in with broader service planning. It would be probably quite helpful for that, I imagine.
And I think if you don't mind me adding, I think the challenge is that when you're putting these long-term strategic investments and future-looking investments into the same pot of some of our acute services that maybe have got needs that are really pressing about in emergency departments and the like, it's a very hard comparison, I suspect. I mean, we're not sitting behind the scenes looking at all of these applications, but I imagine it's a very difficult decision-making process. So, are we comparing apples and apples? Are we comparing short-term, high needs, high risk, as compared to long-term and opportunistic investment, which is where I think we need to be playing for community health?
Yeah, absolutely. And Lee, staying with you, one of the other big shifts that's going through the health sector, of course, is digital health, which has a number of facets to it. The electronic health records, of course, and also virtual health delivery. And for those of you who are familiar with Infrastructure Victoria's draft infrastructure strategy that were released this year, we've got recommendations on continued investment in digital health. Stay tuned, by the way, for the final version of that strategy that's going to be released in November. I know you're all counting down the days. So, Lee, what is the manner in which digital health can help with both mainstream acute and also community health services, and how does that relate to the infrastructure needs of community health organisations?
Yeah, I think there's always a digital conversation that should come when we're talking about infrastructure. I think sometimes they are separated out, but they do come together, and we will be continuing to bring them together in some of our budget submission work. There's been lots of investment in digital enhancements in the Victorian setting. We've seen the Victorian Virtual Emergency Department really have lots of investment across multiple budget cycles. But the opportunity that probably still sits within the community is about investment actually within the community to be able to access that service. So there are many examples of where Victorians might enter into a service such as a community health service and need to access the VVED, want to be supported to access the VVED. So that's about community health services having the right infrastructure to access the digital enhancements that have been made. So whether that's telehealth setups and all the other equipment that's required, not to mention just the digital interconnectivity of being able to communicate, electronic medical records and having that connectivity across both the community health setting, but also into our hospitals and our hospital setting as well. And there's been work done around a roadmap, a digital roadmap. And I think those things around a digital roadmap and an infrastructure roadmap, they really should be complementary.
Thanks, Lee. And how about for you, Anna, what is the role that digital health is starting to play in community health services on the ground?
Yeah, look, most community health services are doing quite a lot of work in this space. And again, I think COVID was probably a bit of a catalyst out of sheer necessity of needing to move services into that realm. We've also seen some really incredible innovation. So each one of the community health services here in Victoria has launched the Virtual Women's Health Service recently with the Victorian government, and we're really seeing already the benefit that that is having in terms of improving access for everyone, but particularly regional and rural communities where, you know, in-person services can be a little bit more challenging to come by. Completely concur with Lee. I think one of the challenges we have is a lot of the digital IT investment that's happening in the health system is very much confined at the moment to hospitals or health services, and doesn't necessarily look at the broader health system. I also think one of the things that Community Health First is calling for in our budget submission next year is an investment in virtual community health services to really build out some of those really more successful models of community health services and expand access that way. So I think the digital piece is an important part of the infrastructure piece for us, Jonathan.
Yeah, and that certainly squares with our understanding of the evidence that we've got about the opportunities that lie for digital health, including to provide regional Victorians with greater and more rapid access to health services. And that connects to some of the other questions that have been coming through on the slide around regional communities and their access to community health and health services more broadly. And of course, in some instances, there's, you know, quite small communities and quite constrained capacity in some of those health services. You know, how does this play out in regional community health services? Are there any particular challenges that they face, and what's the infrastructure connection in some of those regional areas, particularly the smaller communities?
Yeah, look, I mean, I think the important point to make with our rural and regional community health services is often they're the only health service in their communities. So, you know, it becomes even more pressing in those circumstances, the infrastructure investment. So certainly a number of the rural and regional community health services have some really significant challenges with their infrastructure. And we've seen, you know, growing populations in some of those regional centres as well, and that just hasn't been accounted for either. So, yeah, very pressing needs in our rural and regional communities, and often those communities are struggling more so with access than our metropolitan colleagues.
Yeah, and Lee, what's your take on that? Is you got a similar view, or and how does it interplay with you know, the ability for regional health services and regional hospitals to operate and provide a service to their communities?
Yeah, I think what I would extend from that is that, yes, the infrastructure is also challenged in these rural and regional communities, but there's also significant workforce challenges as well. And the infrastructure and the digitalisation of health in rural and regional communities has an impact on the ability to recruit and retain workforce as well. And so I think the investment in infrastructure in those areas will assist with some workforce challenges, but also what we're seeing is that it's absolutely essential as we start to have challenges around GP access, primary care changes, NDIS related changes. So those rural and regional services, as Anna pointed out, are often the only service, and they are the one-stop shop for everything, all the way from meeting the GP needs as well as to the community and the socialisation and the wellbeing needs of people. There is an amazing opportunity in the rural and regional areas as we look to see the hospital network stand up for community health services to be able to provide some of that closer to home care. So I think they're investing in the infrastructure to enable that to happen into the future is imperative.
Yeah, thanks, Lee. And so we're coming close to the end of our time, but we've got some good questions coming through around government appetite to invest in preventative health services and community health services, which would be a bit of a change. And as you said, Lee, we've been starting a conversation on this with our work on community health, both Aboriginal and other forms of community health over this year, because we think it's really important. What's your view, and what would you say to the Victorian government around the opportunities for investment in community health, especially at a time when, as everyone knows, there is limited budget, limited fiscal capacity, and there's a whole bunch of pressures on the health sector and health budgets. maybe Lee, start. Well, I'll start with you on this. Yeah, I know you think about this a lot.
Yep. Thank you. So I think our view would be that the community health core funding that underpins all of the ability of community health to aggregate multiple different funding sources and deliver across both health and social services underpins the strength of the community health model. So over time, there's been a loss in the investment into that service and into that funding stream in comparison to the rising costs. So we've seen the costs of CPI going up year on year on year, and we haven't seen the associated indexation to that core funding. So notwithstanding the conversation we're having about the need to invest in infrastructure, I think what we would say is there needs to be a recalibration of where that core community health funding is at to essentially ensure stable, sustainable and long-term vision for community health sector. The other point that we would make that we think is really important is the burden of the actual funding mechanism. So we are talking about cyclical year-on-year funding that is sometimes insecure. Not dissimilar to the funding cycle and the process for infrastructure. We've got wastage in the system just around that burden, but also the loss of security of the programs and also for staff. So I think there's some opportunities there to really look at where we might uplift the core funding, but also minimise the impact of the mechanism in itself. And I'm sure Anna, in fact, I know Anna has lots to say about this as well.
Yeah.
Correct.
Go ahead, Anna. And while Anna's talking, I'll just remind everyone, you might see in your Slido window, there's a poll that's come up now about get your feedback on this webinar and any suggestions. We'd love you to fill that in before we finish up. But yeah, let's go to you, Anna. What's your take on all of this?
Oh, look, I absolutely concur with Lee. I mean, the community health program funding has not had any measurable increase for more than 20 years. And we know that population growth, let alone the needs of the population, have grown exponentially during that time. So the reality is that all of the infrastructure funding in the world will not help us address the fact that we need to actually invest in the services to deliver to people. Australia is one of the worst countries in the OECD for investment in prevention. We only invest about 1.5% of total health expenditure on prevention. The OECD average is 2.7%, and the reality is it probably needs to be 5%. So I think there's a serious conversation that needs to happen about where our health dollars are going if we actually want a sustainable health system and healthy Victorians into the future.
Thanks, Anna. And Llewellyn, of course, when we did this research, we certainly found some challenges in terms of the way the funding is structured and delivered and the consistency of that for community health infrastructure, didn't we?
We did. And, I think it's already been mentioned the vast amounts of different funding programs which community health organisations are agglomerating. But I guess the challenge of being able to do long-term infrastructure planning with those levels of uncertainty about will funding be renewed, what indexation we will get, the kind of challenge of being able to aggregate enough funding to do a major infrastructure change out of, maintenance funding and, an annual surplus or getting a grant here or there. It's really difficult for these organisations to be able to secure funding for infrastructure from all of these various sources and do so in a planned, secure way that actually allows those funds to be invested most strategically and get the biggest bang for the investment.
Yeah, that's right. And so this has been a start of a conversation. We really hope that you have all found it really useful, the research that we've published, but also the great discussion we've been able to have today. I'd really like to thank Anna, Lee and Llewellyn for their contributions to today's discussion. There's obviously big opportunities for investment in community health infrastructure to release pressure on our hospital system, make the whole health system work better and address the needs of the most vulnerable members of our community. If you'd like to join us for some future webinars, then what I definitely encourage you to do is subscribe to IV's newsletter and our social channels. Our next webinar will be wrapping up on the final version of our updated 30-year strategy. That'll be coming out in November, and we've got quite a lot to say about health sector infrastructure. So that's my teaser for you. I look forward to seeing you all then. But in the meantime, thank you very much for joining us, and a big thank you to Loel and Anna and Lee for contributing to today's discussion. Hope to see you all again another time.